Hi everyone, or just you. I don't really know who's listening, so I'm talking into the ether. Today I want to talk about ALARA in the OR and how our perception of ALARA as coming from radiology is not really the way we probably want to think about ALARA in the OR. Obviously, within radiology, when we consider ALARA, we are looking at, maximizing our SID for the study. In terms of image quality, we are also looking to minimize that OID, so getting the part of interest as close to the receptor as possible. Well, that's not really beneficial to the efficiency of imaging required in the OR. The reason I'm saying that is when you have a patient in surgery, the greatest risk for them is really anesthesia. The radiation dose is very much secondary to everyone else. Clearly, we have to monitor how much we are giving, but the more efficient we can be in our C-arm imaging and the more accurate we can also be, that is hitting ALARA on both aspects. It's minimizing the radiation dose, so that checks our box, but it also gets the case done quicker. And really, that is the preferred outcome and quicker, more efficient imaging rather than the normal principles that we would apply in normal dose reduction techniques. We talk about minimizing OID, all of that other stuff. So those properties aren't really of concern as much in the OR. One example of this, it's a phrase I have coined called the image fulcrum. And what this is, it's where two of your projectional central ray paths intersect. So it's kind of like an isocenter, but C-arms don't technically have an isocenter, so that way of thinking just doesn't really make sense. So if you have an AP and a lateral, you eventually want to work your way within, several back and forths of getting the object of interest in this position where all you have to do is rotate your C without having to make any other changes, either to your boom in or raising your height. Because, most of the functions on a C-arm are manual, so we have some control over the speed. But if you're looking at a control of minimizing your height, i.e. getting the receptor closer to the body part to improve your image quality, the machine goes at its own pace, and a lot of times that adds unnecessary delay. Another, probably the best example I have from my experience is doing inlet and outlet projections for pelvic imaging for SI screws. You want to find that fulcrum where you can only pivot, or where you only have to pivot your tilt function so that you can swing to your outlet and back to your inlet. And when you get proficient, you can really tilt back and forth in about 3 to 5 seconds of each view. And when you consider that a surgeon is standing there holding a drill with the drill tip on this ridge that falls off in an instant, any delay that we insert into that process increases the chance for misplacement or misalignment of that drill bit and requires, a new approach, etc. for the surgeon. So being able to, rather than dropping our height so that we can decrease our OID, really getting that image fulcrum is the much bigger benefit to the overall case. And therefore, ALARA to the patient, you have to look at the assessment of the overall risk of the situation. My history is in trauma imaging, so it was imperative that our surgeries took as little time as possible due to the increased risk from anesthesia on our patient population. This may be something that is demonstrated a little bit easier visually. So over on my YouTube channel, C-Armed, where I have a growing collection of C-Arm demonstration videos, I demonstrate this concept of the image fulcrum on a knee, where my lateral is not a true 90 degrees to the floor. So because of the rotation, that makes it a little bit trickier, but I'll put the link in the show notes, and you guys can have a look at that. Hopefully that makes it make a little bit more sense to you, what I'm talking about with this Image Fulcrum, and just the ease of going back and forth with one lock rather than having to adjust multiple features of the C-arm, which just inserts the unnecessary delay. One of the bigger reasons why I feel this is very valuable for us to be able to image efficiently is it really does cut back on the stress of the technologist. Because when you're in the OR and you're charged with getting these views, you feel that all eyes are on you. And you can feel the surgeon's eyes burning into you if there's this delay. A lot of times they might not really understand the intricacies or the things that we're looking for, but anything that we can do that gives this impression of extra confidence, efficiency, skill, then it really creates a much nicer environment for us to be able to do the job that we need to do. The more that we can exhibit those skills and really define ourselves as that imaging expert that the surgeon expects when they call for x-ray, and we're the ones that walk through the door. So that just about does it. Again, keeping these podcasts a little bit on the short side, just, while I find my feet with the whole process. But please give me your comments, give me your feedback, give me your questions. I really want to look to extend this conversation and, help learn myself and pass on information to others from other shared experiences. So you can email me at ask@thecentralraypodcast.com, and you can also find me on the social media outlets of Instagram, TikTok, and X. You can find me at @centralraypod. And I mentioned earlier in the podcast, if you're interested in seeing or communicating with me through YouTube, you can check out my YouTube channel, which demonstrates some C-arm concepts, and that is @CARMED. CARMED. Anyway, I really look forward to hearing from you. I hope that you do reach out, and I'll catch you guys on the next one. Thanks so much.